up a poll and giving you all 45 seconds for the first one, giving you more options, more time for the first question. Then we'll come back to 30-second poll. 13-year-old boy is brought to the pediatrician by his parents who are concerned about his short stature. He also had recurrent episodes of diarrhea. Serum anti-tissue transglutaminase antibodies are positive. The answer has been given. The upper endoscopy along with the small luminal biopsy is performed. Which of the following histopath changes do you see in the mucosa of the duodenal biopsy of this patient? So not only does this have catch points, it's teaching you a lot about the disease. And what disease are we talking about? When I say anti-tissue transglutaminase, very good. We are going to, perfect. We are talking about the, okay, is there some image? No, there's no image in the question. That's the background that couldn't get changed. So this is going to be celiac disease. This is celiac disease. So do you guys agree that celiac disease definitely has an onset in adolescence and childhood? Do you agree that anti-transglutaminase antibodies are positive in this? Yes. Then do you agree that which is the part of the intestine that is maximally affected? Maximally affected in the part of celiac disease. Okay, so maximum effect is in the duodenum. Before I come to the question, I hope all of you remember that when we talk about celiac disease, what kind of a disorder is it? It is a, what category of disorders does it come under? Yes, not in, yes, it's a brocereal, so malabsorption. I'll say it is to do with malabsorption. Okay, so now when I say malabsorption, you will say that what is the underlying cause? To which cereals? So I hope you know that this is also known as gluten sensitive enteropathy. Perfect, everyone's answering correctly. Gluten sensitive enteropathy. And what are the things that contain gluten in our diet? So all the gluten containing things that you guys have told me. So that is going to be the bro cereals. That is barley, rye, oats and wheat. Barley, rye, oats and wheat. These are the things that contain gluten. So definitely the gluten is creating the problem. But guys, is actually the entire gluten creating a problem, or is gluten having something in it? Is there a problem with the audio? Any issue, any concern with the audio? No, all good. Some of you were having. I hope now the audio is fine. Fine. So when I say gluten, gluten has something known as gliadin, alpha gliadin. This alpha gliadin is the main causative. This is the person causing all the problem. Gluten has something called gliadin. This causes all the concern. Now, I say that celiac disease, when I say celiac disease, it's a disease of all the Ds. It's a disease of a lot of Ds that we have over here. Okay, fine. So what is it? Number one, you'll say it's a malabsorption condition. So patient is definitely going to present with diarrhea. This child over here also had diarrhea. Number two, you have which part of intestine is most commonly affected? It is going to be the duodenum. Is there any skin condition associated with the celiac disease? Dermatitis herpetiformis. Dermatitis herpetiformis. And for the treatment of dermatitis herpetiformis, correct. For the treatment, we have DAPS. So everyone, this is a disease of 4Ds. It has diarrhea, it has duodenum, dermatitis herpetiformis, and dapsone. Audio, I don't know. I see that the audio seems to be fine. Is there still a concern with the audio, guys? All fine, right? Okay, fine. Having said that, now tell me that, okay, this alpha gliadin we've done, diarrhea, duodenum, ye sab ho gaya. What kind of antibodies are formed in these patients? Which type? IgA, IgD, IgM, which kind? Most commonly, which kind of antibody? Yes, most commonly IgA type. Most commonly, not that others cannot form. Most commonly IgA type of antibody that correlates well, because in the skin condition dermatitis herpetiformis, which type of antibody deposition occurs? Over there also IgA type of antibody deposition occurs. So that is what's correlating well, that celiac is also IgA associated, DH is also IgA associated. Now let's come back to the question. Now do you understand how this boy was having diarrhea? Because this is a malabsorption syndrome. Why they've taken the biopsy from the duodenum? Because duodenum is maximally affected. And this patient has anti-tissue transglutaminase antibodies of which type? IgA type. Okay, now coming back to all the options. What are the histopath changes that you saw? Histopath changes that we saw was blunting of the intestinal villi. Okay, guys, I think one or two of you are not able to manage with the audio. So let me refresh the screen. Give me 5 seconds. Okay, so this is the only last resort. On off karna is hamisha the last eureka moment resort that we have. So that I've done. Anything beyond that now, I suppose, will not be in my hand. Okay, so let's continue. So what are the histopath findings that we see in a case of celiac disease? So first and foremost, this is a normal intestine. This is a normal intestine. What are these finger-like projections? These finger-like projections are known as crypt. These are known as villi. These are known as villi. ये जो finger-like होता है ये villi है. And what are these round ones? These round ones are the crypts. Yes. So this happens to be villi, and this round one happens to be crypt. So how is it formed? I'll show you. So actually, this is how the intestine is. That is how the small intestine is. These are all the villi. And when these villi go down, when they dip down, it's just that the blade cuts them in a transverse manner. The blade cuts them in a transverse manner, so they start looking like this. They start looking like a crypt. So this is a villi, the finger-like projection. When it dips down and when you're cutting the tissue, the cut section comes like a round, and that is going to be a crypt. But what do you see in celiac disease? Do you see that those finger-like projections are gone? It's flattened. Number one, do you agree villus atrophy? Villus atrophy. Villi are seen in the mucosa, obviously. Villi are seen in the mucosa, not submucosa. So the villi are totally flattened. Okay. After that, if the villi are totally flattened, someone will try to compensate for the same. So the crypts form below. Can you see the number of the crypts have increased? The number of the crypts have increased. So can I say there is going to be crypt hyperplasia? Crypt hyperplasia, yes. So villi are flattened, and to compensate, I guess 2 or 3 of you are having internet issues at your end. Maybe that is why you're not able to see the image and not having issues with the audio. Guys, please refresh. I have a separate screen open, and as of now, everything seems to be working fine. Okay, so we have the villi that are undergoing, they are atrophied, and then we have crypts which are hyperplastic. So don't you think that overall the overall thickness is maintained? If one is getting flattened, the other is increasing. So the point is that the overall thickness of the biopsy is maintained. Fourth point. So number 3, the overall thickness is maintained. Number 4 point is which is the cell predominantly infiltrating in the epithelium? It is the lymphocyte. Someone was asking me, ma'am, why not option D? Why not option D? Because neutrophilic infiltration is not a feature of celiac disease. The feature of celiac disease is lymphocytic infiltration within the epithelium. So those blue color cells that you have, those are intraepithelial lymphocytes. So again, repeating for all of you with the question, let's go one by one. Do you see crypt aplasia? No, not at all. We see crypt hyperplasia. Crypt hyperplasia. Next, do we see granulomas? No, granulomas are definitely going to be seen in Crohn's disease. Is seen in Crohn's disease. Next, we go on to neutrophilic infiltration. No, we are concerned with lymphocytic infiltration. Do we see blunting of the intestinal villi? Definitely yes. That's the answer over here. Having done with this, let's move on to the next question. It seems to be a very simple one, and I hope you're able to get it in 15 seconds only. So this is a rapid wala question. 40-year-old man who presents with cough with expectoration. Radiological examination shows reticulonodular pattern. Microscopy shows epithelioid cells, lymphocytes, macrophages. What type of hypersensitivity are you suspecting? Only 55% of you are going to have given me a right answer. What are we talking about? Come on, this was easiest. Cough with expectoration, reticulonodular pattern, we were talking about TB. If we are talking about TB, we are talking about formation of a granuloma. And can you see features of granuloma written over here? Epithelioid cells, lymphocytes, macrophages. Now tell me, granuloma and TB are which type of hypersensitivity reaction? Come on, this was one of the easiest questions. This was type 4 hypersensitivity. Not spending more time on it. This was a quick one. Let's go on to this question, and here I'll give you 30 seconds for you to attempt. Here you go. 40-year-old male patient with long-standing history of multinodular goiter presents with a mass measuring 3 by 2 by 1. FNAC shows microfollicular pattern with Hurdle cells. Excision shows an encapsulated tumor with cells arranged in follicles. Capsular invasion is noted, and genetic analysis shows us the presence of RAS mutation. What is the diagnosis? Guys, all your miscellaneous queries about telegram blocking, CVS and micro, वो सब end में करेंगे. पहले हम let's focus on the MCQs. Okay, 68% of you got this right, and this is what the leaderboard looks like as of now. So guys, why did many of you answer papillary carcinoma? Did you see any features of orphan Annie or inclusion, Samoma body? Nothing written over here. It's a very classical feature that there is an encapsulated tumor. So if this is the thyroid gland, this is the thyroid gland, this is the tumor. Okay, encapsulated tumor, and the capsule is being broken. The capsule is being broken over here. Moreover, there is RAS mutation noted. This is a classical case of follicular carcinoma. So first and foremost, let's come to the slide edition. Let's see, when I'm talking about a follicular adenoma, when I'm talking about a follicular adenoma versus a follicular carcinoma, what are the two defining features of differentiation between the same? So follicular adenoma is benign and follicular carcinoma is malignant. Okay, guys, apna okay, right. So when I say follicular carcinoma, this is cancer. So there are two defining features of a cancer. Number one is going to be vascular invasion, and number two is going to be capsular invasion. So when the two invasions are present, I call it a carcinoma. When the two invasions are absent, I call it an adenoma. Let's see pictures. So see guys, can you see this is the thyroid gland? What is this pink material inside the follicles? All of this happens to be the colloid. Then I see a tumor below it. The capsule is this one and the capsule is this one. Is it in continuity? No. Someone from below is coming and breaking this capsule like a mushroom. We call it mushrooming. Can you see the cells are coming from below and breaking that capsule? That is known as capsular invasion. So is this an adenoma or a carcinoma? Capsular invasion present means this is a carcinoma. Image number 2. This entire blood vessel has someone sitting inside it. It has all the tumor cells sitting inside it. Can this be vascular invasion? Yes. So if it is capsular and vascular invasion, it is a follicular carcinoma. Follicular carcinoma shows us RAS mutations. That was also given in the question. Tell me, can FNAC differentiate between these? Can FNAC differentiate between adenoma versus carcinoma? No, not at all, because FNAC can't see the entire blood vessel, FNAC can't see the entire capsule. So can I say one of the pitfalls of FNAC of thyroid cancer is going to be follicular cancer? Coming back to the question, I'll tell you catch points. Papillary ke catch points to sabko pata hai, orphan Annie will be mentioned. Follicular is what you've read over here. Medullary would have had association with what material? Medullary would have had association with amyloid, and any tumor marker that they would have mentioned for medullary they would have mentioned calcitonin. That was also not mentioned here. Anaplastic is something which doesn't fit into any of these, the worst tumor. So that doesn't have any catch points, but it's the worst, yes, the worst tumor that we have in the thyroid. Okay, coming to the next one, again, a very simple one, I suppose. And starting the poll, 30 seconds, I think should be good enough. Okay, 40 seconds. Dr. Himani mentioned hallmark cell. Okay, I'll come back to that. No, we are talking about anaplastic carcinoma of thyroid. That doesn't show me hallmark cells. Anaplastic lymphoma shows me hallmark cells. No, all anaplastics are not the same, है ना? So anaplastic lymphoma shows me hallmark cell. Fine. So 54% of you have got this right. This is a classical case of diagnosis is given, that is hairy cell leukemia. I taught you these genetic tests 2 weeks back. So I'm expecting all of you to give me a correct answer onto that. And last 5 seconds. Perfect. So 47% of you have given me a correct answer. I want to just bring up this history a little bit. You have, please focus, I'm talking about hairy cell leukemia. So everything that has been mentioned over here is a very important catch point of hairy cell leukemia. First and foremost, hairy cell leukemia occurs in the elderly population. It occurs in the elderly population. Suffering with a dragging sensation in the abdomen. When we have dragging sensation in the abdomen, examiner is always trying to tell you towards massive splenomegaly. So remember that when the examiner in a hematology case, let me tell you, in a hematology case, when the examiner is telling you massive splenomegaly, if the examiner, like यहाँ तो diagnosis लिखा था, but when you start reading, you don't know what the examiner is talking about. But when we are talking about massive splenomegaly, keep 3-4 diagnoses which are most commonly asked. One is in terms of leukemias, it is CML, very good. Then we have leukemia lymphoma में hairy cell leukemia, primary myelofibrosis, and Kala Azar. First, in pathology, look out for these 4 things that the examiner, most likely 99% cases you'll be able to solve with these 4 only. CML, hairy cell leukemia, primary myelofibrosis, and Kala Azar. Here we saw later on, peripheral blood shows pancytopenia with monocytopenia. Yes, hairy cell leukemia shows you pancytopenia, fine. But why are we highlighting monocyte count being specifically less? When the monocyte count is not there, what infection are more? Which infections are more in hairy cell leukemia? Yes, atypical mycobacterial infections. Because the monocytes are not there, atypical mycobacterial, again a previous year question, these are going to be more. Do you guys remember the atypical mycobacterial infections, the table? What is that classification known as? Going a little bit into microbiology. What is that classification? Ranyon's classification. Very good. So do you remember that photochromogen, scotochromogen? I'm giving you time, always confused. So I'm giving you time for today. Tomorrow I'll post mnemonic of the day. Okay. On YouTube, I'll be posting mnemonic of the day and I'll tell you how to learn that entire table in exactly 1 minute. It's the easiest table. But I'm giving you time. Put your brain into it. Think of something. Tomorrow I'll tell you. Okay, so now this patient shows you monocytopenia, and that is why we see atypical infections. Now you know everything. Hairy cells are seen, hairy cell leukemia ho gaya hai. The marker of hairy cell leukemia is annexin A1, and what is the marker of apoptosis? The marker of apoptosis happens to be annexin 5. For hairy cell leukemia, annexin A1. What are the genetic studies of hairy cell leukemia? All hairy cell leukemia, 100% hairy cell leukemia cases show you BRAF V600E mutation. So do you know exactly which codon I have to go and target? So when I know exactly which codon I have to go and target, when I know my base, the single base that I have to target, I use single base primer extension. That's what the answer was. Single base primer extension when I know the locus, when there is a known locus. How else could the question come? Over here it came with respect to BRAF. It could come with respect to JAK2 V617F. What would be the history given to you? Like a history of polycythemia vera. So a very lengthy history would be given to you. But in the end, if you know your exact codon to target, you will answer single base primer extension. Is that okay, everyone? Should we move on to the next MCQ? Again, a very lengthy one, but very, very easy. So I'm going to give you only 30 seconds for that. Good. So 80%, 87%, everyone's doing well. Okay, now the poll is falling a little, but never mind. 64%. Okay, what syndrome are we talking about and what tumor are we talking about? Everyone's told me 50% finally. Okay, so one question ignored out of this because वो true false wala tha, so consider them as 5 questions only. Now we come to the next thing, that is, I think the history is pretty easy. You've got flank pain, you've got cases of hematuria out here, and you've got a mass in the renal mass. Isn't that the classical triad of renal cell carcinoma? Renal cell carcinoma presents to you with flank pain, hematuria, and a renal mass. That renal mass is having clear cytoplasm. So which kind of renal cell carcinoma are we talking about? Let me show you the picture. Yes, all the cells are looking white. All the cells are looking white. So that is clear cell renal cell carcinoma. Clear cell is the most common type of renal cell carcinoma, third alphabet. Na? C is the third alphabet. So it is the most common type. It is associated with chromosome 3p deletion. Chromosome 3p deletion leads to which syndrome? Three alphabets, von Hippel-Lindau syndrome. Repeating, clear cell, most common, third chromosome is deleted, VHL syndrome will occur. Let me read the question again. Do I have features of VHL syndrome? Yes, you had a mother's history who had hemangioblastoma. So remember, when we come to VHL, all angio things will start coming up. In the brain, there is going to be hemangioblastoma. In the brain, there is going to be hemangioblastoma. In the liver, there was a tumor and they don't know the diagnosis of the tumor. Again, angio tumor of the liver. All of you are saying hemangioma. लिवर में कौन से टाइप का हेमांजियोमा होता है? कैपिलरी और कैवर्नस? एनी ऑर्गन, विच टाइप ऑफ हेमांजियोमा? ऑर्गन्स में यू हैव cavernous hemangiomas. Yes, so in the liver we have cavernous hemangioma. Other than that, any other angiomatosis that is put up to you in the any other angiomatosis that is put up to you, or retinal angioma, yes, anything to do with the word angio is going to come up in this VHL syndrome. The renal tumor that we talk about is RCC. It's the clear type of RCC, and the clear type of RCC has chromosome 3p involvement. Guys, what about the rest? What is this chromosome 7, 17 and chromosome Y? Chromosome Y, which kind of renal cancer? Y matlab papa. Y matlab papa. These were all papillary. These were all papillary carcinomas of the kidney. Papillary RCC, all of them. So this was quite an easy one here onwards. Okay, moving on to the next question. Again, I'm putting up only a 30-second poll. Here you go. Okay, very good. So I think the diagnosis is clear. It's a fact-based question after that. The history pretty much is useless. If you know this image, the question becomes easy. Spotter image, बस उसका special stain पूछा है. That is it. You have a 55-year-old woman who comes to the pathology lab. Hemoglobin 12, good enough. TLC 10,000, time to revise your normal values. TLC normal is going to be 4,000 to 11,000. So this is under normal range. Differential count is neutrophil 60, lympho 30, mono 6, EO4. What is the descending order? What ये तुम लोगों का एक famous mnemonic है, very useless kind of a mnemonic. Never let monkeys eat bananas, so they have to be in the decreasing order. Never let monkeys eat bananas, right? So NLMEB, NLMEB, that needs to be in the descending order. Neutro, lympho, mono, EO, baso. Neutro, lympho, mono, EO, baso to 0 ही होगा. So they are in the descending order. Everything is fine. Platelet count 1,70,000. The normal platelet count, time for revision. Normal platelet count 1.52, 4 or maximum 4.5 lakhs, not above that. So platelet count normal. HbA1c 11%. that is markedly elevated, very high, and that is why the urine is showing you glucose 3 plus. Renal biopsy shows you this finding, which is very, very characteristic. This is your favorite KW lesion, but I want you to tell me the other name for KW lesion, which is actually asked in the paper. Other name for KW lesion is nodular glomerulosclerosis. It is nodular glomerulosclerosis. So you will see a glomerulus, which you can see over here. You will see sclerosis because this is all pink material. And all that pink material is in the form of nodules. Nodular glomerulosclerosis. So they ask you, what is the special stain for this pink material? And the special stain for this pink material is PAS. Can you see they've become more magenta pink like? PAS always gives a magenta pink color, right? So all of these are PAS positive. Coming back, this is what they showed you, the KW lesion, and PAS positivity is what you have. But I want to ask you something. ZN stain, though we know it is for TB and all acid fast things, I'm not asking you. Alcian blue is for? Alcian blue is a stain for? Very good. Alcian blue is a stain for mucin. Which type of mucin? A for A. Acidic mucin, neutral mucin. Very good. Alcian blue is a stain for acidic mucin. Verhoff Van Giesen. Verhoff Van Giesen is a stain I taught you yesterday morning only. Verhoff Van Giesen is a stain for elastic fibers. They had no relation with this question over here. So easy to rule out. Okay, let's move on to the next set of questions. And here you go. The poll, 30 seconds. I know it's a long STEM question, but quite having a lot of catch points. So 30 seconds mein try karo. Easy one, I suppose. These are time-waste questions where they give you a long stem and then you realize, oh, the question is from general path. And once you realize that, the answer takes 1 second to come. 83% of you got it right. The others have called it option A, which is not right. So let us see the leaderboard as of now. Going very, very good, guys. So here you have a 46-year-old healthcare worker, fever, fatigue, loss of appetite, productive cough, pretty much how every patient in our country presents, because this is a case of TB. Sputum is thick, blood tinge, weight loss hai, night sweats hai, there is a consolidation, all well. When I look at the DLC, never let monkey eat bananas. Is it in the descending order? No. I can see the lymphocytes are increased. The lymphocytes are high. Do you expect the lymphocytes to be high in a case of tuberculosis? Yes, it can be high in a case of tuberculosis. So when I'm talking about TB, let us go one by one. So naked granulomas are seen, not at all in TB. Naked granulomas are a feature of which disease? Naked granuloma is a feature of sarcoidosis. Fine. Okay, granuloma formation is seen with Anishkau cells. Some of you answered this. Anishkau cells are a feature of rheumatic heart disease. This had zero things about rheumatic heart disease, not going too much in favor of the same. Okay, palisading granuloma is seen. Where do you see a palisading granuloma? This is what I want to ask you. Palisading word mat dekho siraf. Please remember palisading granuloma. Palisading granuloma. Guys, you are just telling me schwannoma and all without reading the other word. Granuloma kahan? Achha, very good. Rheumatoid arthritis. Rheumatoid arthritis. Some of you said schwannoma. Schwannoma is a neural disease. Does it show you a granuloma? Not at all. Some of you said brain tumor, that is glioblastoma. Does glioblastoma show you a granuloma? No. We are just not looking at the word palisading. It's a palisading granuloma. So rheumatoid arthritis and even Wegener's granulomatosis. At least use the word granuloma in it, right? Wegener's granulomatosis can also show you the presence of a palisading granuloma, which was not the case over here. This was a classical case of TB where you had granulomas with Langhans giant cells and macrophages. Examiner basically just wasted a lot of your time. How else could the question come was this: what are these giant cells? These very famous giant cells are the Langhans kind of giant cells. And do you see this blue color collar around this granuloma? This blue color collar is the lymphocytic collar. Very good, lymphocytic collar. I want to ask you, what kind of lymphocytes are usually found in TB? CD, TH1. So TH1 matlab CD4 type. Yes, TH1, that is CD4 type of T cells are what are noted, is what they ask you in the paper. Why? Because TH1 cells release what? TH1 cells release what? That results in the formation of a granuloma. Yes, Th1 cells release interferon gamma, and interferon gamma, G for G. Interferon gamma is the one that helps in the formation of a granuloma. Okay, moving on to the next